you today and share my presentation. Today I'm going to talk about thyroid eye disease from a strabismus surgeon's perspective. Thyroid eye disease severely impacts the quality of life of thousands of young through late middle-aged patients. As we all know, thyroid eye disease starts with an active disease, which is characterized by inflammation, and then followed by the inactive disease, which is characterized by fibrosis. And during the inactive disease or the fibrosis phase, this is when we can do strabismus surgery. If there is intractable diplopia in the primary gaze or the reading, or an abnormal head position, or if it is cosmetically unacceptable. The symptomatic patient is always keen on having something done very early, particularly when their thyroid functions are under control. Although Graves' disease and thyroid eye disease both stem from an immune attack, but both run separate courses, and the treatment of the thyroid condition does not improve the eye condition, so we have to keep this in mind. So we need an evidence-based approach in order to manage such patients. Fortunately, we have these very valuable publications which are available online by the European group and the American Association. So we can treat these patients by the guidelines. First, we assess the activity of the patient and the severity. The activity, we use the clinical activity scoring. A score of below 3 is usually considered inactive, but we have to be aware about inter-observer variability in the clinical activity scoring. So we have to look for other forms of activity, other criteria for activity, such as the thyroid stimulating immunoglobulin, which is less than perfect, but helpful. And also for a strabismus surgeon, the MRI is more valuable than the CT scan for the evaluation, particularly for the signs of activity. Our question is, which sequence do we choose? The fat suppression STIR sequence is very useful because we compare the signal intensity in the temporalis muscle to the signal intensity of the extraocular muscle. If the extraocular muscle is enhanced, then this is a sign of activity and it can help us in the diagnosis. There are other sequences such as the coronal Water-Dixon, which is more sensitive, and recently the diffusion-weighted imaging is being used because it proved to be more sensitive. So we choose with our neuroradiologist which sequence we choose. And then we assess the severity using the UGOGO classification. We usually do not do early surgery unless there is any sight-threatening complications such as compressive optic neuropathy or severe corneal exposure. And if the disease is active, moderate to severe, our first-line treatment is intravenous pulse steroid. Of course, there are many other treatments available, like the fully humanized monoclonal antibody Tepezza, but of course it's very expensive and we didn't try it yet. Whatever form of treatment, it is important to know that the treatment does not change the natural time course of the disease. So, our question is 6 months of stability enough before performing a strabismus surgery? The answer is unfortunately not, particularly if the patient is early on in the timeline. If the 6 months of stability are before the passage of 18 months, or maybe up to 3 years in a smoker, then probably the patient may reactivate. Once we are sure the patient needs surgery and is stable, the orbital surgery is performed first before any strabismus surgery. The investigations that we have to do before the surgery is the field of binocular vision, a forced duction test, and the assessment of ocular torsion. Our goals is a single binocular vision in the primary and down gaze. For horizontal deviation, it's basically simple that we do a medial rectus recession, although we have to keep in mind that the standard surgical nomograms do not apply. We either release the restriction or match the duction deficit. Most surgeons prefer adjustable sutures, but it has been proven that the fixed sutures also have comparable results. And we can get away with a small resection if needed, particularly after we have done a full recession. For vertical deviation, it's a little bit tricky because when we're going to do a vertical deviation, most likely we're going to do an inferior rectus recession. The question is whether we're going to do a bilateral or a unilateral recession. We cannot depend on the magnitude of relative hypotropia, but the degree of fixation duress. We assess the fixation duress by putting an occluder in front of the more hypotropic eye and check the chin-up position. If the chin-up position does not improve, then we're going to do a bilateral inferior rectus recession, and most likely this will improve the lid position. And to minimize late overcorrection, if we're going to do a large inferior rectus recession, we have to keep in mind to undercorrect a little bit and accept a little chin-up position. There have been many postulations for the cause of late overcorrection. One is a short arc of contact between the globe and the inferior rectus, or the use of absorbable sutures, or a clinically subclinical postoperative inflammation. But the most often culprit is excessive superior rectus tone. So we have to do a forced duction test before any surgical dissection to detect this, and if found, we have to undercorrect the inferior rectus recession. When doing a large inferior rectus recession with a large medial rectus recession, an A pattern may happen, and this we may avoid by titrating the amount of medial rectus recession to maintain a slight chin-up position. Also, an encyclo torsion can happen with a bilateral inferior rectus recession. We can assess it using a Mendez ring intraoperatively after the induction of anesthesia, and we mark the skin and the cornea, and then after the recession we check if the amount of torsion. Finally, we have to anticipate the tight muscles such as the superior rectus, as we said before, when we found a minimal extorsion, and if the misalignment, is across the board. I mean, if there is comitance across the board. And anticipating a tight superior oblique is very important. This also causes a minimal extorsion. We can assess it by after recession of the inferior rectus. We do a traction test to check for a tight superior oblique. Thank you very much.